This is a talk on sodium disorders. Clinicians seem to have particular hang-ups when it comes to sodium disorders. Maybe it's due to the incomplete information we often have when we're seeing these patients, or maybe it's an aversion to math. Whatever the case may be, I'm going to try to teach you everything you need to know about sodium disorders in less than an hour. I've distilled the topic down as much as I possibly can, but you're still going to have to do some math. This talk dovetails with my previous talk on fluid management, so I'd suggest that you see that talk first before listening to this one. I'm going to start off with a review of some pathophysiology and then go over hypernatremia and hyponatremia disorders in turn. Here are some definitions we commonly use when we're talking about fluids and electrolytes. The osmolality is a measure of the total number of particles, or osmoles, dissolved in a kilo of solution, which is essentially the same as the osmolarity, where the denominator is in terms of liters of solution. The effective osmolality, or tonicity, of the extracellular fluid space refers to the total number of electrolytes in solution that contribute to water movement across the cellular membrane, which is mainly the sodium plus potassium and associated anion concentrations in the plasma. The sodium and potassium concentration gradient across the cellular membrane is maintained by sodium-potassium ATPases, and this gradient is what restricts sodium, along with chloride, to the extracellular fluid space and maintains the extracellular fluid volume. An osmol like urea passes freely across the cell membrane, so it's termed an ineffective osmol. Therefore, any changes in plasma urea concentration will not lead to any net movement of water across the cellular membrane. Changes in tonicity is what leads to translocation of water across cellular membranes. The tonicity is determined mainly by the sodium, potassium, and chloride concentrations, since these ions are present in the highest concentration in the plasma or extracellular fluid space. Free water refers to fluid that contains no electrolytes such as D5W. Isotonic fluid is a solution that has the same effective osmolality as plasma. So for normal saline, the total concentration of electrolytes is 308 milliequivalents per liter, which is similar to the osmolality of plasma. Any saline you give to a patient will stay in the ECF space. D5W and normal saline are isoosmolar, but not isotonic given their differences in electrolyte content. The dextrose in D5W is there to prevent rapid movement of water intracellularly when you give it intravenously. If you were to give sterile water, then cells would swell rapidly where you would develop cerebral swelling or red cell lysis. So naturally, you're not going to want to do that. This slide shows the distribution of water in the body. In general, for a man, about 60% of the total body weight is made up of water. In women, it's a little less, or 50% of the body weight. And in the elderly, where you're going to see some shrinkage, it's about 40% of the body weight. So when you're doing calculations to determine treatment for sodium disorders, be sure you use the appropriate percentage of water making up the total body weight. You're usually going to want to use the ideal body weight in morbidly obese patients, since they will have a smaller percentage of body weight that's made up of water. ADH, or antidiuretic hormone, acts on the collecting duct to reabsorb water from the glomerular filtrate. So elimination of water depends on how much ADH is present in the plasma. A rise in serum sodium, or effective osmolality, will stimulate ADH secretion to increase water retention and lead to thirst to increase water intake, thus lowering the sodium level back down to normal. A fall in intravascular volume may also stimulate ADH secretion. As circulatory volume falls, baroregulation overrides the osmoregulatory system, and hyponatremia may then occur. Here you can see how urine volume decreases and becomes more concentrated as ADH levels rise. Humans with normal kidney function have the capacity to produce urine with a concentration ranging from less than 100 to 1,000 milliosmoles per liter. Here you can see that in a normal individual depicted by the solid black line, ADH levels rise as the plasma osmolality rises, but if you become hypovolemic, the slope of the curve steepens, and you see a more rapid rise in ADH as the osmolality goes up. So hypovolemic hyponatremia occurs when there's a significant drop in intravascular volume, which if you'll remember from my fluid management talk, can only be determined by assessing the central veins and by checking orthostatics. In reset osmostat, represented by the red line, there's a shift in the curve to the left, where both ADH secretion and thirst occur at a lower plasma osmolality. So there can be a persistent mild hyponatremia. Treatment isn't necessary in these patients since most of them are asymptomatic, the hyponatremia is mild, and these patients will drink more water anyhow if you try to correct the sodium, so treatment tends to fail. A reset osmostat can be seen in pregnancy, epilepsy, paraplegia or quadriplegia, and in certain malignancies secreting ADH. In general, sodium disorders occur when there's a problem with water intake, ADH secretion, or water excretion by the kidneys. So now I'm going to review hypernatremia, which occurs as a result of excessive water loss by the kidneys or an inadequate intake of free water. Symptoms from hypernatremia, such as lethargy, weakness, and irritability, can occur due to shrinkage of brain cells. Seizures and coma can also occur in severe cases. Hypernatremia can occur due to unreplaced water loss from insensible losses, vomiting or diarrhea, diabetes insipidus, and osmotic diuresis, hypothalamic lesions impairing thirst or osmoreceptor function, primary hypodipsia, or reset osmostat and mineralocorticoid excess. Sometimes, dehydration can be due to bilateral lacrimal hypersecretion as you're trying to learn about sodium disorders. Okay, not really. That was a joke stolen from Dr. Zubin Damania, also known as Z-Dog. Other ways in which hypernatremia can develop is from water loss into cells from severe exercise or seizures. Seizures can raise the serum sodium level acutely by as much as 10 to 15 milliequivalents per liter from generation of new osmoles that are retained in skeletal muscle cells that cause water to shift from the ECF to the intracellular compartment. In terms of treatment, for hypernatremia present for more than 48 hours, the rate of correction should be no more than 10 to 12 milliequivalents per liter per day. Acute hypernatremia can be corrected more quickly. In acute hypernatremia, within hours, the cell will take up sodium and potassium and chloride to compensate for the hypernatremia. In chronic hypernatremia, brain cells will adapt by synthesizing osmolytes that prevent movement of water out of the cells. But this protective adaptation can lead to an increased risk of cerebral edema with rapid correction of the sodium level. So you have to be more cautious when correcting chronic hypernatremia. Keep in mind that a diabetic with hypernatremia from a non-ketotic hyperosmolar state is usually volume depleted. So the initial treatment should be normal saline to replete the volume first, and then hypotonic fluid to correct the serum sodium level. Typically, these patients will have a serum sodium of greater than 154, so you'll still see some correction of the serum sodium level with normal saline. The water deficit equation shown here can be used to determine how much water to give to correct the hypernatremia. We now have all kinds of apps like MedMath where we can easily plug in the variables to calculate the water deficit. Remember that if you're also repleting potassium with KCl in the fluid, you have to account for that in determining how much free water you're giving the patient. For example, if you have a hypernatremic patient with hypokalemia and you're wanting to give 40 milliequivalents of KCl per liter of fluid to replete the potassium, you might want to put 40 milliequivalents of KCl in a liter of quarter normal saline, which would give an osmolality of 157 milliequivalents per liter, which is about the same as half normal saline. So each liter of that fluid you give will be providing 500 mils of free water. The water deficit equation doesn't account for ongoing insensible losses of free water or urinary losses of free water. So if you just replace the volume determined by the water deficit equation, you'd undercorrect sometimes to a significant degree. To fully correct a hypernatremia, you have to replace insensible losses along with urinary losses of free water. This becomes critically important in patients with diabetes insipidus. To determine ongoing urinary losses of free water, you need to divide the urine sodium plus potassium concentration by the serum sodium plus potassium concentration to get the tonicity of the urine relative to the plasma. So if this is 0.3 or 30%, then 70% of the urine volume excreted will be free water, which must be replaced along with the water deficit. Another way of quantifying this is with the formula shown on the bottom of the slide, where the urine free water clearance is equal to UV times 1 minus the urine sodium plus potassium concentration divided by the serum sodium plus potassium concentration, where UV is the urine flow rate in mils per hour or any unit of rate you prefer. This can require intensive monitoring of urine and plasma electrolytes and urinary flow rate unless the patient has essential DI, often due to permanent injury to the pituitary, where the urine concentration is relatively fixed. Most of the time, in patients who are hypernatremic and dehydrated, you don't have to worry too much about replacing urinary losses of free water since it's usually insignificant. It's usually with DI that you need to consider replacing ongoing urinary losses of free water. Here's an example of an elderly female with DI from lithium. Her initial sodium level is 149, but rises to 167 over the next 24 hours. Her urine lights are as shown. If you want to correct her sodium level by 12 milliequivalents over the first 24 hours, you would calculate the water deficit, which is 0.4 times her weight, which is 60, times her current sodium divided by desired sodium minus 1, which equals 1.9 liters. The tonicity of her urine relative to her plasma is 0.75, and assuming that her urine output and tonicity remain the same over the next 24 hours, 25% of the urine volume excreted over the next 24 hours is lost as free water. So if her urine output is 4 liters over 24 hours, 1 liter of free water will be lost through her urine. Insensible losses of water will be about 0.5 mils per kilo per hour. So in a 60 kilo person, that's 30 mils per hour of insensible losses times 24 hours, which equals 720 mils or 0.72 liters. So the total water deficit that needs to be replaced over 24 hours is 1.9 plus 0.72 plus 1, which equals 3.62 liters. If you give the water in the form of D5W, it would be given at a rate of 3,620 mils divided by 24 hours to give 151 mils per hour. Here's an interesting case report of a young man who was admitted with severe hypernatremia after drinking a quart of soy sauce on a dare. About 2 hours after drinking the soy sauce, he became comatose with seizure-like activity. In the ED, he received lactated ringers at 200 mils an hour and was then switched to D5W and half normal saline at 200 mils an hour and free water per NG tube at 150 mils per hour when his sodium level came back at 177. 2 hours later, the sodium level had risen to 182. He was then intubated, and 6 liters of D5W was given over 30 minutes by the 5th hour post-ingestion. Over the next 24 hours, he received 5.2 liters of D5W, 215 mils of water per NG tube, and 2.4 liters of additional hypotonic solutions. His urine sodium peaked at 270 and urine osms at 963. So you can see he received a huge volume of hypotonic fluid within the first 5 hours. The initial water deficit was calculated to be about 13 liters to correct to a sodium of 140. Here are his labs over the first 5 hours. Note that his serum sodium level had to be corrected for the hyperglycemia, which was presumably due to diabetes from acute pancreatitis. Fortunately for him, he was able to recover completely from this and went on to college, where I'm sure he learned his lesson never to try a stunt like this again. Because hyperglycemia causes osmotic shifts of water from the intracellular to the extracellular space, leading to a lower sodium level, the sodium level in the presence of significant hyperglycemia needs to be corrected since the sodium level will rise once the hyperglycemia is fixed. This is the formula used to calculate the corrected sodium level when hyperglycemia is present. The corrected sodium is equal to the measured sodium plus 2.4 times the glucose level minus 100 divided by 100. This is the same formula used to correct the sodium level due to pseudohyponatremia from hyperglycemia. It's been shown that in hyponatremic patients with severe hyperglycemia, the corrected sodium level correlates better with clinical outcomes such as mortality. Now I'm going to talk about hyponatremia, which is most often caused by the non-osmotic release of ADH. The incidence of hyponatremia in hospitalized patients is common and can occur in up to 15 to 30% of those patients. A few years back, there was a local radio station that had a water drinking contest for the winner to win a Wii video game console. This was a very sad case where the winner ended up dying from hyponatremia just to win a Wii console for her child. During the contest, she drank one 8-ounce bottle of water every 15 minutes initially. One guy quit after 5 bottles. They then moved to larger bottles. I don't know how much water she ingested, but she clearly exceeded her kidney's capacity to excrete water, and several hours later, she was found dead at home after complaining of a severe headache. On average, no more than 8 ounces or 237 mL per hour is recommended. The healthy kidney can process 15 to 20 liters of water a day, but studies of water loading in non-exercising athletes have indicated a peak urine excretion rate of 778 mL per hour, but there's a 60 to 90 minute delay after a water load before maximal excretion of water occurs, so the max hourly intake of water needs to be much less than that. In general, small individuals with low total body water can develop hyponatremia more easily from relatively little positive water balance. Risk factors for cerebral edema from hyponatremia include menstruating females, elderly females on thiazide diuretics, children, psychogenic polydipsia, and hypoxemia. The signs and symptoms of hyponatremia are nonspecific, but can include nausea, vomiting, lethargy, ataxia, delirium, weakness, muscle cramping, headaches, and in cases of severe cerebral edema, seizures, coma, respiratory depression, and death. Okay, so now I'm going to take you back to medical school and talk about the countercurrent mechanism in the kidney. This figure shows how water is reabsorbed by the nephron. Up to the thin loop of Henle, solutes are reabsorbed with passive transport of water. The thick ascending limb is impermeable to water, so reabsorption of solute in this segment of the nephron allows for trapping of solute in the medullary interstitium, creating a concentration gradient from the outer to the inner medulla. Then, under the effects of vasopressin, water is reabsorbed along the collecting tubule through water channels leading to concentrated urine. The reabsorption of sodium chloride without water in the medullary aspect of the thick ascending limb is normally the primary step in the generation of the hyperosmotic gradient in the medullary interstitium. In the presence of ADH, the highly concentrated interstitium allows water to be reabsorbed in the medullary collecting tubule down a favorable osmotic gradient between the tubular lumen and the interstitium. Loop diuretics inhibit sodium chloride reabsorption in the thick ascending limb of the loop of Henle. So administration of a loop diuretic interferes with the countercurrent mechanism, and although a loop diuretic can increase ADH levels by inducing volume depletion, responsiveness to ADH is reduced because of the impairment of the medullary gradient. So the development of hyponatremia will be limited unless distal delivery is very low or water intake is very high. The thiazides, on the other hand, act in the cortex of the distal tubule. As a result, they don't interfere with medullary function and therefore with ADH-induced water retention. In some cases, the combination of increased sodium and potassium excretion due to the diuretic and enhanced water reabsorption due to ADH can result in the excretion of urine with a sodium plus potassium concentration higher than that of the plasma. Loss of this fluid can directly promote the development of hyponatremia, independent of the degree of water intake. So there's an increased risk of hyponatremia from thiazide diuretics as opposed to loop diuretics. As with other diuretic-induced fluid and electrolyte complications, hyponatremia develops within the first 1 to 2 weeks of therapy if the diuretic dose and dietary intake remain relatively constant. After this period, the patient is in a new steady state in which further sodium and water loss don't occur. Although later onset has been described, such patients must have some disturbance in the steady state, for example, the development of heart failure or an increase in diuretic dose. Because urine osmolality is a composite of both electrolytes and solutes excreted, free water excretion is also dependent on the total rate of solute excretion besides decreased ADH. So a patient eating a low sodium chloride and low protein diet can develop hyponatremia, especially when another mechanism for hyponatremia is present, like a vegetarian who exercises excessively or an elderly person consuming a tea and toast diet and taking a thiazide diuretic. A low solute diet, low in sodium and protein by itself, can lead to a mild persistent hyponatremia. With low solute intake, free water excretion is reduced because at least 50 milliosms of urinary solute excretion is required to excrete each liter of maximally dilute urine. So hyponatremia develops when fluid intake exceeds the maximum volume of urine that can be excreted based on the available solute. I had a colleague who once told me about a patient with a persistently low sodium level of around 130 to 131, and it turns out that this patient was a baker by profession and ate only bread every day, so his low solute intake led to a persistent hyponatremia. There are several mechanisms which can lead to hypovolemic hyponatremia or hyponatremia from a volume-depleted state. With hypovolemic hyponatremia, several factors can lead to the perpetuation of the hyponatremia. Decreased distal delivery of water, as in renal failure or volume depletion, increased secretion of ADH, and increased thirst leading to increased fluid intake. Individuals with decreased distal delivery of water will improve with saline administration, where ADH secretion decreases as volume is restored. Volume depletion is also often associated with potassium losses, for example from diarrhea, vomiting, or diuretics. Loss of potassium depletes intracellular stores, leading to a transfer of sodium from the extracellular to the intracellular fluid space to maintain extracellular volume and tonicity. So hyponatremia from volume depletion should be treated with potassium if hypokalemic and normal saline to replete the volume. Sometimes overcorrection of the hyponatremia can occur simply by repleting the potassium. So be sure to replete the potassium first while monitoring sodium levels before giving normal saline, or give normal saline conservatively if the rate of correction is a concern. Saline should probably be avoided in patients with hyponatremia in the setting of CHF, cirrhosis, or nephrotic syndrome, since it will end up being retained, worsening their volume status. These patients should be treated with fluid restriction and loop diuretics instead. This is a formula you can use to estimate how much potassium to give in patients who are hyponatremic and hypokalemic at the same time. The increase in sodium level after a liter of fluids is equal to the infusate sodium concentration plus infusate potassium concentration minus serum sodium concentration divided by total body water plus 1. Sometimes, if you have a patient with significant hyponatremia and hypokalemia, just repleting the potassium can lead to a significant correction of the hyponatremia. To help you understand this, let's say you give 1 liter of normal saline to a 70-kilo male with a sodium level of 110. The change in serum sodium level will be 1 milliequivalent, so the serum sodium will end up at 111 milliequivalents per liter. But if you now add 40 milliequivalents of KCl per liter of normal saline, then giving a liter of this will lead to about twice the change in the sodium level, or 2 milliequivalents, where the serum sodium level will end up at 112 milliequivalents per liter. So if you're also repleting with oral potassium, you can expect a much steeper rise in sodium level without having to give any additional saline. So in patients who are both hyponatremic and hypokalemic at the same time, try repleting the potassium first and see what happens with the sodium level before giving too much saline. This is one approach to diagnosing hyponatremic disorders. You want to start off by checking the serum osmolality, sodium, potassium, creatinine, and the urine osmolality, sodium, and creatinine, and assess the intravascular volume status, which is different from the overall volume status, since a patient can be overall volume overload from cirrhosis, let's say, but be intravascularly volume down due to third spacing of fluid into the abdomen. The best way to do this is to assess the central veins and check for orthostatic changes in blood pressure and heart rate. Serum osmolality determines whether the patient has a true hyponatremia or pseudo-hyponatremia. The patient has a true hyponatremia if the serum osmolality is low. If the serum osmolality is normal or high, then the patient may have a pseudo-hyponatremia. Pseudo-hyponatremia occurs when a lab uses indirect potentiometry to measure the sodium level where excess lipids or proteins may take up a significant volume in the plasma, falsely raising the plasma volume used to calculate the sodium concentration. Most labs, including ours, use the indirect ion selective assays to measure sodium levels, so pseudo-hyponatremia needs to be considered if the serum osmolality is normal or high. One way to get around this is to measure the sodium level with an I-stat machine, if available, which will measure the true sodium level using a direct ion selective assay. Hyperglycemia and propylene glycol, a common solvent used in IV meds in the ICU, can lead to hyponatremia from the osmotic effect of glucose or propylene glycol drawing water extracellularly. If it's a true hyponatremia, a urine osmolality will tell you whether the patient is appropriately or inappropriately diluting the urine to increase free water excretion in the setting of hyponatremia. If the urine osmolality is less than 100, the urine is appropriately dilute, and primary polydipsia or beer potomania should be considered. A urine osmolality greater than 100 suggests that there's an inappropriate increase in ADH secretion. You then need to look at the urine sodium and intravascular volume status. If both are low, then it's consistent with hypovolemic hyponatremia. Most cases of hyponatremia occur due to low intravascular volume status. Volume status can be estimated by checking for JVD, orthostatic changes in blood pressure and heart rate, increased BUN to creatinine ratio, evidence of hemoconcentration, a low urine sodium of less than 20, or fractional excretion of sodium less than 1%. If the urine sodium level is high and intravascular volume is down, then primary adrenal insufficiency, cerebral salt wasting, and diuretics, where you have renal wasting of sodium, should be considered. If the urine sodium level is high and the patient appears euvolemic, SIADH, secondary adrenal insufficiency, hypothyroidism, ACE or ARBs, and thiazide should be considered. Most patients with euvolemic hyponatremia excrete sodium and chloride that reflect dietary intake, so sodium will be greater than 30 and the fractional excretion of sodium greater than 1%. Burns, vomiting, pancreatitis, and diarrhea cause hyponatremia through a non-renal loss of sodium. Hyponatremia from glucocorticoid deficiency results from a failure to fully suppress ADH release in response to hypoosmolality. In mineralocorticoid deficiency, renal sodium wasting leads to hypovolemia and a secondary volume stimulus to ADH release. Patients with hypopituitarism generally do not become volume contracted because they maintain adequate aldosterone secretion to prevent renal sodium wasting. Consequently, volume replacement with isotonic normal saline does not reverse the impaired water excretion of patients with secondary adrenal insufficiency as it does in primary adrenal insufficiency. Hyponatremia is only seen in patients with hypothyroidism who've progressed to severe degrees of mixed edema, so hyponatremia is uncommon in primary hypothyroidism. When hyponatremia accompanies hypopituitarism, It's usually a manifestation of secondary adrenal insufficiency from glucocorticoid deficiency rather than coexisting hypothyroidism. The major cause of impaired water excretion in hypothyroidism appears to be decreased renal perfusion in GFR from the systemic effects of thyroid hormone deficiency on cardiac output and peripheral vascular resistance. Primary polydipsia can be seen in psychiatric disease, infiltrative disease in the CNS like sarcoidosis, or critically located brain tumors, so patients with polydipsia should be evaluated with a CT or MRI of the brain before concluding it's from a psychiatric cause. Thiazide-induced hyponatremia is quite common and can be seen in up to 13.7% of patients treated with thiazides. There's a higher risk in elderly females and malnourished individuals. If you're taking care of patients in the ICU, you need to be aware of this. Propylene glycol is a common solvent used in IV drips given in the ICU setting, such as lorazepam, diazepam, esmolol, nitroglycerin, phenobarbital, phenytoin, trimethoprim sulfamethoxazole, and others. Any unexplained hyponatremia associated with a high anion gap metabolic acidosis with an elevated osmolar gap, which is the measured osmolality minus the estimated osmolality, should prompt the diagnosis of propylene glycol toxicity. It may also cause CNS depression, arrhythmias, and renal dysfunction. This is a list of commonly used drugs associated with hyponatremia. Thiazide-related hyponatremia can give you a SIADH-like picture, frequently occurring within a few days or weeks after initiation of therapy, and is typically seen in elderly females. If thiazide-induced hyponatremia is noted in an individual, that person should not be rechallenged with a thiazide, as hyponatremia is likely to recur. SSRIs and tricyclic antidepressants can also lead to hyponatremia that may be difficult to distinguish from SIADH. The risk is greatest in elderly patients and tends to resolve days to weeks after stopping the drug. How antidepressants lead to hyponatremia is unclear, but patients will often meet the criteria for SIADH. DDAVP, of course, and certain antiepileptics like carbamazepine and lamotrigine can also lead to hyponatremia. The chemotherapeutic agent vincristine has also been associated with hyponatremia with a greater risk among Asians. While we often have incomplete information when we're seeing hyponatremic patients, there are 5 key questions we want to ask when we're deciding how to address the hyponatremia. The first is, does the patient have symptoms? If the patient's symptomatic, then the sodium level may need to be more urgently corrected with 3% hypertonic saline. 2. Is the hyponatremia acute or chronic? If chronic or present for more than 48 hours, then a slower correction rate is necessary to avoid the osmotic demyelination syndrome. 3. Does the patient have risk factors for neurologic complications like alcoholism or malnutrition? If so, then the rate of correction needs to be more conservative. 4. What's the patient's volume status? This is extremely important because it helps us diagnose the cause and determine the appropriate treatment to correct the hyponatremia. The key to treatment of hypovolemic hyponatremia is to first establish that intravascular volume depletion is present. If present, then with correction of the volume deficit, the relative water excess will correct itself. When the initial volume status is equivocal, a fluid challenge with 500 to 1,000 mL of normal saline can be both diagnostic and therapeutic. In hypovolemic hyponatremia, the sodium level will rise, but with SIADH, the sodium level will fall. In general, hypovolemic hyponatremia is treated with saline or volume repletion, and hypovolemic hyponatremia is treated with fluid restriction and diuretics. Number 5, is hypokalemia present? If hypokalemia is present, potassium should be repleted first, if asymptomatic, since even a partial correction of potassium depletion can cause an excessive rise in serum sodium even without saline administration. With chronic hyponatremia, the brain cells can extrude organic osmolytes to decrease the cytosolic osmolarity and prevent cerebral edema. Osmotic demyelination syndrome, or ODS, can be a complication of severely rapid correction of the serum sodium level in someone who's undergone substantial brain adaptation. It typically involves the central pons, but can extend to extrapontine structures. It's clinically manifested by hyperreflexia, pseudobulbar palsy, quadriparesis, Parkinsonism, locked-in syndrome, and even death, and can arise 1 to 7 days after overcorrection of the hyponatremia. MRI findings might take 2 or more weeks from the initial neurologic manifestations before becoming evident. The injury is irreversible more than 50% of the time, but I'm aware of a case where a 21-year-old male with a history of panhypopituitarism on hydrocortisone, thyroid, and testosterone replacement therapy had stopped taking his meds 5 days prior to presenting to an urgent care clinic for dizziness and weakness, where he received 2 liters of normal saline for hypotension. His initial sodium level was 100, and 6 hours later, after receiving the IV fluids, his sodium level had risen to 116, and then rose to 124 24 hours later. In the ED, his urine lights revealed a urine osmol less than 100 and a urine sodium of 22. Keep in mind that IV saline can raise the urine sodium level. He was likely hyponatremic from a combination of increased fluid intake, which was habitual for him, hypovolemia, and adrenal insufficiency. A week later, he developed symptoms of inappropriate affect, ataxia, and diplopia, which were attributed to extrapontine myelinolysis based on an MRI of the brain. Fortunately, he fully recovered after several weeks, and a repeat MRI over a year later showed resolution of the findings seen previously on the MRI. In hindsight, he probably should have had his sodium level lowered back down to 108 or so in the first 24 hours to reduce the risk of ODS. He was at increased risk of overcorrection once his hormone replacement therapy had been restarted, which would have led to autocorrection of his hyponatremia without the need for saline. Here's a list of risk factors for the osmotic demyelination syndrome. In alcoholics, the syndrome may not have anything to do with changes in serum osmolality. Potassium depletion in the brain may actually hinder cells from osmoregulating as well. Malnutrition, cirrhosis, burn injuries, and thiazide-induced hyponatremia are other risk factors for ODS. Patients with these risk factors should be corrected with more caution. The initial treatment of hyponatremia depends on how severe the hyponatremia is and whether severe symptoms such as seizures or obtundation are present. If the patient is symptomatic, 100 ml of 3% hypertonic saline can be given over 10 minutes up to 3 doses, or until there's a 4 to 6 ml equivalent per liter increase in the sodium level, whichever comes first. Then correct slowly not to exceed 6 to 8 ml equivalents per liter in the first 24 hours. This treatment should generally be enough to alleviate symptoms and prevent herniation of the brain from cerebral edema. If there are no symptoms present and the serum sodium is less than 120, diagnosis-specific treatment can be given to limit the rise in sodium to less than 6 to 8 milliequivalents per liter in the first 24 hours and 18 milliequivalents per liter in 48 hours. In states where there's an increased risk of overcorrection, such as hypovolemic hyponatremia or adrenal insufficiency, 0.25 mils per kilo per hour of 3% saline plus DDAVP 1 microgram IV Q6 hours to reduce the risk of overcorrection should be given in the first 24 hours. If there's a lower risk of overcorrection, which is typically in SIADH, then you can start 0.5 mils per kilo per hour, 3% saline, and titrate up or down depending on the rate of correction. A D5W bolus or drip and/or DDAVP can be considered if overcorrecting. There's no evidence that a quick but limited increase in the serum sodium is harmful, for example, a rise in the sodium by 2 to 4 milliequivalents per liter within 2 to 4 hours, as long as the overcorrection over 24 hours doesn't exceed 6 to 8 milliequivalents per liter or 18 milliequivalents per liter in 48 hours. The diagnosis of SIADH can sometimes be challenging and is a diagnosis of exclusion, but a list of diagnostic criteria for SIADH is shown here. In general, other organ systems are normal. the urine is inappropriately concentrated with a urine osmoles greater than 100 and a very high urine sodium level. With severe SIADH, the urine osmolality may be in the 600s range. The uric acid and BUN levels are typically due to hemodilution from water retention. Patients tend to be euvolemic. A normal saline challenge will lead to a lower sodium level because the urine is highly concentrated, so any sodium chloride you give will be excreted in a small volume of urine, while the rest of the volume you give will be retained as free water. Fluid restriction is often necessary to help correct the sodium level. There are a number of causes of SIADH that I've listed here. I'm not going to go over each one in detail, but in general, nausea, pain, stress, certain malignancies, pulmonary disorders, CNS disorders, drugs, and hereditary mutations in the ADH receptor can all lead to SIADH. SIADH can be a paraneoplastic syndrome as well, associated with certain ADH-secreting tumors like small cell cancer of the lung. This example explains why we want to give 3% hypertonic saline initially rather than normal saline to correct a hyponatremia in a patient with SIADH. In this example, we have a 60-kilo woman with a sodium level of 115 and urine osmoles of 680 consistent with SIADH. What happens if we give a liter of normal saline? 1 liter of normal saline contains 308 milliosmoles per liter, so if we give 1 liter of normal saline to her, we're giving 308 milliosmoles, which will be excreted in a very concentrated smaller volume of urine. If we divide 308 by 680, we get 0.45 liters of urine. So this 308 milliosmoles of sodium chloride will be excreted in 450 mils of urine. More than half of the liter of normal saline she's given, or 550 mils, will be retained as free water, leading to a lower sodium level. We can calculate this by determining the total effective osmoles present in her body, which is her total body water times the plasma sodium times 2, to account for the chloride present, which gives 6,900 milliosmoles. The new sodium level after giving her a liter of normal saline would be 6,900 divided by 2 times her new total body water volume, which is 30 plus 0.55 liters that was retained as free water, yielding a new sodium level of 113. So if you're treating someone with SIADH with 3% hypertonic saline, how do you do it? Well, there have been a number of equations that have been proposed to calculate the appropriate rate. As it turns out, all these equations come up with about the same rate of correction using hypertonic saline based on this New England Journal of Medicine article because they're all making the same basic assumptions. What they found was that administering 3% saline at a rate of 1 to 2 mils per kilo per hour will correct the serum sodium at a rate of 1 to 2 milliequivalents per liter per hour. If you want to correct the sodium at a rate of 0.5 milliequivalents per liter per hour, you'd give 3% hypertonic saline at a rate of 0.5 mils per kilo per hour based on ideal body weight. You can use a higher rate, for example 2 mils per kilo per hour for acute or severe symptoms and a lower rate for milder symptoms. And monitor the sodium level every 2 hours, adjusting rate of the drip as needed. These calculations are all estimations based on certain assumptions, so there's no substitute for sodium monitoring. You can also add a loop diuretic to dilute the urine if there's no response. Fluid restriction to less than 500 to 1,000 mils per day can then be considered. Here's an example of how to give hypertonic saline based on a calculation of the sodium deficit. If you have a 70-kilo man with a current sodium level of 110 and the desired sodium level is 120, then the sodium deficit would be the total body water times the desired sodium minus the current sodium level, or 0.6 times 70 times 120 minus 110, which equals 420 milliequivalents. Since 3% saline has 512 milliequivalents of sodium per liter, the total volume of saline that needs to be given is 420 divided by 512, or 0.82 liters. Over 24 hours, this works out to a rate of 34 mils per hour. If you calculate this the simpler way we just went over, you would divide the total number of milliequivalents of sodium you want to correct over 24 hours by 24, which would give you a 0.42 milliequivalents per liter per hour correction rate. So the hypertonic saline would be given at a rate of 0.42 mils per kilo per hour, or 0.42 times 70 kilos, giving you a rate of 29 mils per hour. Once the sodium level has been corrected, fluid restriction is generally needed, usually to less than 800 mils per day, to maintain a normal sodium level. Sometimes salt tablets can be added in addition to fluid restriction to maintain a normal sodium level. For asymptomatic SIADH, where fluid restriction is not working, urea can be used to help correct the sodium level. In this study, oral urea was shown to be a safe and well-tolerated treatment for SIADH without over-rapid correction of sodium levels. The main side effect is a bitter taste. We'll typically give 15 grams per day if the urine osmosis is between 300 to 500 milliosmoles per kilo, and 15 grams BID if the urine osmosis is between 500 to 600 milliosmoles per kilo. Over the last however many years, vasopressin receptor antagonists like tolvaptan have been promoted for the treatment of euvolemic and hypervolemic hyponatremia in the hospital. But I wouldn't recommend this class of drug for the treatment of hyponatremia, given the difficulty in predicting how much the sodium level will correct for a given dose, the frequent overcorrection of the sodium level, and some evidence showing a trend towards increased mortality. Here's an actual case of hypovolemic hyponatremia that illustrates how autocorrection of the sodium level can occur quite rapidly upon repletion of volume. This was a man with a history of schizophrenia who was admitted with altered mental status after a day of nausea and vomiting and polydipsia, where he drank 12 bottles of water. On admission, he received a normal saline bolus, followed by 3% saline at 20 mils per hour. At first, his serum sodium level rose slowly in the first 5 hours from 107 to 109. Then he suddenly corrected to 116 at 9 hours and then 129 at 18 hours. His urine osm suddenly fell from 364 to 108 over 5.5 hours, while his urine output picked up significantly to 3.6 liters. As you can see, once he was volume resuscitated, ADH secretion was shut off, leading to a sudden water diuresis and correction of the sodium level. He did well, even though he was overcorrected, likely due to the acute nature of the hyponatremia and the lack of risk factors for ODS, and was eventually discharged without sequelae. So here are some final takeaways. Hyponatremia is commonly caused by the non-osmotic release of ADH due to low intravascular volume. In general, repleting the volume with normal saline will lead to the correction of the hyponatremia without the additional need for hypertonic saline. Overcorrection of hyponatremia tends to occur with the correction of volume-depleted states, potassium repletion with hypokalemia, discontinuation of thiazides or other medications causing SIADH, and cortisol or thyroxine replacement, which can each rapidly reverse the defect in water excretion and thus cause a brisk aquaresis and rapid autocorrection of the hyponatremia. So treat the underlying conditions first and monitor sodium levels for improvement before considering saline administration. Note that ODS is uncommon when the serum sodium is greater than 120 and the hyponatremia is acute in nature. In general, to avoid ODS, correct by less than 6 to 8 milliequivalents per liter per day, especially if the acuity is unknown or risk factors for ODS are present. Symptoms from hyponatremia tend to occur when the sodium falls to less than 125 acutely. Finally, symptomatic hyponatremia is a medical emergency, so the sodium level needs to be raised quickly with small boluses of 3% hypertonic saline.